So I think one of the things that I have found early on in my practice is that with interacting with the healthcare system is that there's so many different pieces coming together, financially especially. Early on I noticed immediately with a lot of our oral drugs that our patients need, our insurance companies weigh in quite a bit in terms of which selections to make, which was a big surprise to me, having a non-clinical person who doesn't really understand the disease biology telling me really what to do with my drug choices. So I think I found myself really being an advocate for my patients in those situations, really fighting for them to get access to the drugs that they really need. And that comes up very commonly for non-small cell lung cancer in particular, where there's about 3 or 4 different molecular alterations we look for, and they have 3 or 4 drugs for each of those. And there's certain reasons why I might pick one for one patient or the other based on the toxicities or where the disease might be, which ones I want a really rapid response for, where someone maybe I don't need that for as much. Sometimes it is a more expensive drug, that's just the fact of the business. And so I think we find some issues with insurance companies saying, hey, why don't you use the cheaper version, especially for those non-small cell lung cancer patients. And with that being sort of the most common disease, there's about 220,000 cases of non-small cell lung cancer in America every year. This is an issue that comes up a lot. I do find, with patients when these types of insurance situations occur where they're blocking access to a certain drug, it's very stressful, I think, for both of us, really. Many of them they're very sick at the time. They really need something to get control of their cancer and their disease rapidly. And so it's a lot of phone calls to our offices just asking, hey, what's going on? I heard you sent this prior authorization in, what's going on with that? We get several calls a day, and I fully understand. This is literally their lives. And I want to do the best thing for them as fast as possible. So I think it's a little bit of a balance of, managing their anxiety about it, but also my own, and sort of pushing to get what needs to be done sooner. When I think about junior, people that are in fellowship and things now going into practice and into the future, I would say, just look at yourself not just as a physician, but as an advocate within this global picture of, all of these different financial forces from insurance companies, hospital systems, and also just the cost of what we do as well. I think, we don't think enough about out-of-pocket costs for our patients too. So I would just say, I think we need to be a little bit more global in terms of not just knowing the science of oncology, but also the finances of it as well.